Hey, y'all.
Hey.
Instead of Happy Baby Friday, it's actually Happy Friday this
Yes,
week
happy
because we
Friday.
switched our days for us to be able to get my friends and colleagues and great esteemed panel here for us today, as we're going to be talking about a couple different things. But first, to all of my Irish kinsmen, fellow kinsmen, Benacte Fea Padre Orf. So happy St. Patrick's Day to everyone early. And I hope you have some good fun in eating your Irish bacon and cabbage on Sunday. I never could. Oh, that was one thing. I gotta love my Irish grandmother, but whew, I just the cabbage thing. I just never never could do it. It was
I
not one of my
love
favorites.
cabbage. It's one of my faves.
Oh, see, a lot of people that's like their favorite thing, and I was like, oh, yeah, ma'am, I really, I love you, but
My
uh,
mom's like you. She does not like cabbage.
It's an acquired taste.
It is.
yes, like liver. Oh,
I love liver.
oh, see, oh.
Oh my gosh.
For those of y'all joining us, we have with us today, up to the my upper right in the Hollywood squares here is Pam Vanderbilt. And underneath her, we have the lovely Laidy Martinez. And then right underneath me, we have the wonderful Kimberly Jolivette Williams. So we are all here to just kind of, I thought it would be fun to get kind of a group of people together to talk about the G2211, because everybody's talking about it everywhere, and we still are trying to get our heads wrapped around what it is. So I thought it might be nice to hear some different opinions. And Pam, because Pam is the owner of a billing service, she might be able to give some different perspectives on what she's seeing on that, and then maybe talk too about the Change Healthcare cyber attack. Once again, Pam being the billing service queen over there, can, maybe give a little pearls of wisdom of things that she's been doing to help her clients out that have been affected by the Change Healthcare cyber attack. So just those are the kind of two things I wanted to hit on today and kind of discuss. But as always, we'll take all y'all's questions as they come in, and we're pretty much open to anything that we can help you with. And between the four of us, we at least should probably be able to give you some kind of an idea for something, if nothing else, right? So I'm seeing we have a lot of people starting to come in. So Shanna saying, hey, ladies. So, hey, Shanna. And Maud is saying hello.
Hey, Maud's one of our chapter officers.
Oh, there you go. Hey, Maud. Marie Popkin. Oh, and Shanna's giving you a whoop whoop, Kimberly. So
Happy Friday.
and John Piaskowski's joining us, our coding cheerleader. So glad to have you, John. And
hey, John.
He said the G2211, his brain is already mush. So we will try to give you some different ideas on it, or different things, because I think just like anything else in coding, there's not just always one right answer or one right perspective. There's many different ways to think about a lot of different things that we do. And I think E&M especially is one of those like places that can be super gray, right? Where you can look at something and, well, if this, but I looked at it this way. And, so I always think it's fun and interesting to talk things out like that with other people, just to get different perspectives. Pam, I know you and I were talking about it offline, the G2211, I think yesterday or day before when we were chatting, and you even kind of brought a different perspective than, I had originally been thinking about it. So I just thought that, it'd be really cool to do this. So so everybody, we will start with just our G2211. And for those of y'all that are, chiming in and saying hey to everybody, as you have questions or have opinions on this, please go ahead and pop them in the chat, and we will, pull it up in our conversation. And Ladriba, hey Ladriba, she's one of my favorite new people. So I am mentoring her, helping her along, and she's going to be really great in the field. She's a great newcomer with the right attitude and passion. So I'm watching her and helping her. So all right. Any of the three of y'all want to start with what you think about G2211? Good, bad? What are we doing?
I know for us right now, I'm in the process of trying to come up with I think the best thing we are trying to do as an organization is come up with our own policy, right, of how we want to handle it. Because I think there's so much out there that is just so broad, right? So I think even my company, we do PCP, we do hospitalist, we also do specialty, right? And so I think depending on what they do, you kind of got to have a policy for your company, because there's too much broadness out there to kind of know what to do in certain situations. So when I think about it, I keep thinking, okay, we got to come up with our own rules of how we're going to define longitude, they don't care, right? That big word I can never pronounce, right? How are we going to define that? And then what are we going to set up in place and do education? But again, that's just my Kimberlyism, right?
How about you, lady? What are y'all doing for G2211?
Pretty much the same thing. My organization is developing a policy just to ensure that since there's no clear guidance from CMS and in particular, like, different specialties, we wanted to make sure we kind of train all our providers across the board and making sure they understand, and then we give the guidance. And at least if it ever comes back that we need to add it, well, we can just say, hey, we have a policy right here written, and this is how we went by. So I think you can never go wrong by that. I think it is, since it's so new, I mean, it's not a new, it's just that it just came in effective. I mean, it's not been a new code. It's been for 3 years, but it was on hold. So because it just given an effective, I think sometimes it's best to be conservative. And when you're going to the providers and making sure that they understand clearly what your policy states. And once you have that, then you can start billing back. And I think I put this when I wrote my article with NAMAS, I think it's best to create a policy before I start billing those codes, because I mean, I'm pretty sure there's so many people that have already been billed, and there are going to be more denials than actual payments. Right?
Try to be proactive and not reactive, right?
Yes.
So I think being conservative, I think it's okay to be conservative and not just start billing it, because you're going to have more work later on.
Yeah. Now, Pam, from your side of it with the billing company, are all of your clients like jumping on the G2211 bandwagon? Are they kind of, I mean, I know sometimes it's specially specific. If you're all surgeons, they're probably not using a lot of it, but for the ones that it's kind of applying to, are they asking you questions about it? Are they saying, hey, let's give it a try?
Yeah. So, no, not for most of my surgeons, because we don't have that. We don't meet the definition requirement from the specialty perspective, right?
Right.
But a majority of my clients are actually primary care providers. And we actually did education with them prior to January 1st, and had that conversation. And, admittedly, when a budget actually gets passed, who knows what's going to happen, right? So they may have giveth and they may still taketh away. But for right now, it is an active code. And I highly recommended to my providers that they use it when they're reporting evaluation and management services for their primary care patients. Now, I've got a couple of practices that they do walk-in visits, and they have patients that take advantage of the walk-in that are not established with them for primary care. So they're not using it for those visits. But everything else that's not being reported with a 25 modifier and is being reported with 99202 through 99215, they're using it. And part of my rationale, and we were kind of talking about this offline, but the definition we got is word soup. It kind of doesn't make a whole lot of sense. It's like, what the heck, right? But the examples that we've been given through change requests and other information that has come out from CMS has really kind of, if you just kind of take the definition out of your head and look at the examples that they've published, it actually makes it a little bit more clear how to use it appropriately. And I feel very confident from a compliance perspective that I am not worried about my providers using this code in the least bit, because if I go back to some of the older guidance, I actually think they gave better examples than the newer guidance does. Newer guidance says we're seeing the PCP and they're having a sinus infection or something, right? And or they see the infectious disease and the patient has HIV. But there's a change request that came out at the end of last year that addresses the G2211. And there's three really important things. And I'm reading off of page 9 from this change request that I can't remember the number of off the top of my head. But
11842.
There you go. So they tell us three things that I think are really important to understand that we can support these services. Number one, it includes services that enable practitioners to build a longitudinal relationship with all patients, and then in parentheticals, that is not only those patients who have a chronic condition or single high-risk disease. And I think that's important to note because a lot of us on that auditing and compliance world kind of got hung up on that single condition, high-risk condition, right? So they tell us that's not all it is. Then when they give us the examples, example number one, in the context of primary care. So we are not talking about our specialists in this one. We're only talking about our primary care providers, right? In that context, G2211 could recognize the resources inherent in holistic, patient-centered care that integrates the treatment of illness or injury, management of acute and chronic health conditions, and coordination of specialty care in a collaborative relationship with the clinical team. Well, tell me what that excludes from a primary care perspective unless they're doing urgent care. It doesn't really exclude anything, right? And then example two, in the context of specialty care, this code could recognize the resources inherent in engaging the patient in a continuous and active collaborative plan of care related to an identified health condition in the management of which requires the direction of a clinician with specialized clinical knowledge, skill, and experience. Such collaborative care includes patient education, expectations, and responsibilities, shared decision-making around therapeutic goals, and shared commitments to achieve those goals.
I think, and I cut and pasted those all into the
that
chat.
Was so nice, Betty. Someone, Joel even said, "Thank you so much, Betty. So helpful."
Yes, I agree.
But I think when they decided to make it active, if they would have went back to this change request, we wouldn't have all of this conversation that we were having about it right now. And people wouldn't be as confused. Is when they made this silly definition, and we were talking about this. I mean, the definition, it's a whole paragraph. Just kind of be straightforward with the definition, please. Just make them better. But it's like visit complexity inherent to the E&M associated with medical care services that serve the continuing focal point for all needed healthcare service and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. And I think that's the part that was tripping everybody up, is the end of it. single, serious, or complex condition. So then when CMS comes up with that example of the sinus congestion, everybody's going, wait, what is so serious and complex and chronic? And, you know, it doesn't mean any of that, but you're giving that as an example. And then CMS tried to say, you know, it's not about the condition, it's about the relationship.
That's right.
But I think people are still getting hung up on what they used as an example.
Yep.
And
that's
so
the thing.
Right.
kind of put everybody in a tizzy.
Yes.
We
But
put 'em
even
in
me,
context.
yeah, I'll be honest, when I saw sinus infection, I'm like, wait a minute, because me even being an asthma allergy person, I had to process that, like for myself. Wait a minute, if I go to the doctor and he evaluates me, am I going to qualify as a patient for a G2211, right? Because it is something that, you know, is ongoing. It could be considered chronic, you know, and depending on what's going on, I've even had bronchopneumonia, right? Which could be a serious condition. So just putting my own personal, you know, conditions to it and seeing how it would apply, I had to analyze that myself. So I definitely understand why, and especially, you know, what it makes me scratch my head, because when I think of all of us on here, we have so much experience, just the four of us on here, and we were scratching our head. So I empathize so much with the new, you know, people that's coming new to this business of healthcare arena. I could see why they're so confused.
Well, and you know, after January 1st, we kept saying, you need to give us documentation requirements, because we all know we don't get paid for something unless we can show the work, right? And we got an MLN, but the MLN actually said you cannot report it on a visit where we're using modifier 25.
Right.
Okay. So we have a black and white rule, but you didn't answer our documentation requirements question, right?
Yeah.
The last MLN that came out, I think it was in February. I've lost track of my days now.
It is MM13473.
Yeah. That one actually said there are no additional documentation requirements.
Yeah.
And I'm guilty. I was telling people, you got to say something in your note to support, because if we're going to ask them for more money, we got to tell them why we want it, right? They made it very clear. If you appropriately document your evaluation and management service, that documentation in and of itself supports the G2211. And then they also said that they're going to use data. So do you have that longitudinal relationship? If you're a specialist, do you meet the qualifications about the diagnosis? So they're going to use data for those as well. But we do not have to tell our providers, you got to create a macro for this. That is absolutely not what the most recent guidance is.
Right here, and while y'all are talking, I just put the Medlearn matters that we're discussing, and now I'm going to put in what it says about the documentation there. So it says you must document the reason for billing the outpatient other E&M visit. The visits themselves would need to be medically reasonable and necessary for the practitioner to report G2211. In addition, the documentation would need to illustrate medical necessity for the E&M visit. We haven't required additional documentation. Our medical reviewers may use the medical record documentation to confirm the medical necessity of the visit and accuracy of the documentation of the time you spend. So they're going to make sure that the level 3 is a level 3. But, you know, to your point, Pam, you know, you don't have to make a little template box or something in your EHR that you click that says, I have a longitudinal relationship with this patient. You know, so yeah, they really are not asking us for anything, which kind of, you know, my first take, so to speak, on the G2211 was it was kind of like a bonus payment for primary care guys. You know, it was like to give them that extra bump, because we have our surgical specialties that, yes, all do E&M. They have to see the patients before they do surgery and all that stuff. They see them after surgery. They, you know, so they do see patients from an E&M standpoint, but they don't live off the E&M. Whereas with primary care doctors, yes, they do some minor procedures, they do some other little things and immunizations and stuff like that. But those docs and APPs, live and breathe off their E&M services for the most part. And, I think that's how, when the G22, the way that it came out, I was like, okay, that's kind of what it seemed like to me. That was a way to give them kind of a bump without affecting every single thing, to where the conversion factor and, the RVUs and blah, 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 and all that kind of stuff. But, make it a little add-on code. They get that little bump, in what they're doing. So that's really was my look at it when they first started pushing that they were going to do it. But you do have a lot of specialty practices, orthopedics, dermatology. They'll see patients that have psoriasis. They see patients that have acne, and and they're giving the care for that condition only, and that's who that patient's seeing. And with some of those bio, medications that are given, they need to have that kind of relationship with that provider that's doing that for them. So, I'm glad it's not just for primary care. It's for anyone that's taking on that extra kind of, and I don't want to say burden because it's your patients, but taking on kind of like that extra job on your back thing. But in my head, that's kind of how I looked at it.
I completely agree with you, Betty, because when we first saw, back to Laidy's point, this isn't a new code. It just was not active for us, right? This came out prior to the 2021 E&M changes. And the intention that was given to us back then was that it was predominantly for our providers who were E&M driven practices, non-surgical practices, right? And at that point, they anticipated that we would use it 100% of the time.
Yep.
What? Okay. That tells me you expect us to use it, not we've got to jump a whole bunch of hoops to use it, right?
Yeah.
I do think, though, one thing that keeps niggling in my mind, when we talk about that longitudinal relationship, that means that we've established a relationship with the patient that's been going on for a period of time. We've created that trust relationship with the patient, right? I'm still struggling why the new patient office visits are included in reporting this, because when they're a new patient, we have not established that longitudinal care yet. That's the compliance person in my head, right? But where's the longitudinal in that relationship?
And I think go ahead. No, go ahead, Betty. I don't want to cut you off.
I was just going to say that was what surprised me too. I was like, established patient all day, but new patients, what if the patient never comes back then?
Yes.
You see them once and then they go somewhere else. So
and I think
I'm bothered by the new patient thing. Kimberly, Lady, how about y'all? I know Kimberly.
Yeah, I was saying that's what is puzzling, but I think that's where the confusion come in, because if I had to come up with my own Kimberlyism best practice, I would think that they're leaning toward that single complex chronic to define that they can use that G22 in addition to what they're calling establishing that longitudinal relationship. But again, that's why I say you have to create your own internal policy about this, because they don't give any definitions. I attended a wonderful presentation. It was like a webinar that Shannon Dakana did over G211, and she too said, what is a single serious condition, right? What is a complex condition? CMS doesn't define that for us. So internally, we're going to have to come up with our own best practice. Not that we have to make them do something that CMS is not saying, right? Because they do say no documentation is required. But we all know when Big Brother calls and you can't defend or answer the question of why this was done, you need to have something to protect yourself, right?
Yeah.
So that's where those internal policies and next steps are going to have to come into play, because we do have to understand how are you going to justify this on a brand new patient that walked into your office. So you should have some kind of internal best practices, right, to support that. That's my Kimberlyism on it.
Yeah. Lady, how about you on the new patient thing?
I totally agree that it has to be having a relationship of continuity of care. So it's, to me, it's just the same way as Pam and Kimberly were saying. It has to be, that relationship has to be established first in order to provide this. I mean, I think new patient, exactly, you don't know if the patient is going to come back to this practice. So it has to be a relationship, a continuity of care before we actually start using this G2211.
And I see also in the comments from Barb Shaw. Hey, Barb.
Hey, Bob.
That she had a provider meeting
Mhm.
and they were talking about the G2211 in the provider meeting. So if they had any, like good tidbits that they kind of provided, Barb, from their perspective, we would love to have you, put them in the chat box and, make some comments about it to add to the discussion here. So it's just, I think it's tough. I think different facilities are going to look at it different ways. And I think it might even be because we have the CPT weird, super long definition, and then we have CMS saying that, we're talking about this single serious condition or complex condition, and then giving an example that doesn't quite seem to fit. But I'm thinking maybe it might be one of those times where you're going to have, since it's a G code, it's not a CPT code, we're going to have that to where the AMA is viewing it in a certain way. And, Medicare, they make the G, they put the G code out there. They're looking at it in a specific way. Maybe we're going to see something from CPT, as like a counter to this. And, who knows? Because the other thing is, remember, it's a G code. So this is not something that you can be putting on every patient you see, because some commercial payors have no clue what this code is. I have heard, though, Pam, have you seen, because again, with the billing, that I have heard people saying that they have commercial payors that are actually paying on this code.
So we don't bill it to true commercial payers, but we are billing it to Medicare Advantage payers. They are required by law to cover anything Medicare covers, and we are getting paid. Now, they did not turn on the active status quite as quickly as CMS did, so that we did have some that we have to rebill. But all in all, the ones that we are currently billing at this point, we are receiving payment on first pass. So they've gotten it turned on. So,
right. So,
and just John asked a question, and I think it's a really fair question, because I have heard this over and over again. Can more than one provider provide longitudinal care for the same condition? Remember, it's the relationship with the patient and not the condition itself that's driving what we can do. And it makes a difference. Are we talking about it from the primary care provider's perspective, because they're providing longitudinal care for all of the patient's healthcare needs, whereas the specialist is focused on that single serious or complex condition, right?
Yeah.
So absolutely, our PCP can be providing longitudinal care for any condition. And we may also have a specialist who is the point of relationship for the single serious condition. So my answer based on those two pieces is yes, they can. But, when we start getting into specialty and subspecialty, nobody has said we can't use it. And if I go back to, they gave us this code pre-2021 and they expected it to be used by our E&M driven providers 100% of the time. I'm going to have to tell you, I think their expectation is yes, as long as it is an E&M driven specialty, that it doesn't matter how many people are treating the patient for that condition. That's my panism.
I think if you think about it, if you're seeing your primary care, and let's say you see, I have my atopic dermatitis was just going bananas on me for like the past 4 months. And as a, Pam, as being a Floridian, that's something that we deal with a lot down here. So, and trying to get into your dermatologist sometimes is not the easiest thing to do down here. And so if you're at your primary care's office who has your longitudinal care. So when I was at my internist, I was like, could you please, dear Lord, take a look at, because I am like dying here. Can you just give me something till I can get in to see my dermatologist? Well, so the primary care, I mean, the dermatologist then isn't seeing me for every single time I have every single thing. So, I mean, just because the primary care is seeing me that day and helping me with that problem doesn't mean that it excuses the dermatologist now they can't do it, or the primary care now shouldn't be able to do it because they didn't see me before. So, it's about that. Again, they're looking at that relationship. So if you're having those little things where you're having issues, I don't think it's, going to throw anything off if somebody's reviewing records and going, oh, but you saw the dermatologist for this most of the time. Yeah. So yes,
Yeah.
I agree with you, Pam.
Yeah, me too. Yeah, because I definitely think about me and my other kind of conditions outside of my asthma and allergy, right? And so anytime I go to my internist or PCP, then they would be able to do it. But my asthma pulmonologist doctor, he could do it too, right? Depending on what that situation is. So I agree. As far as it appears right now, as long as you have that documentation in that office outpatient visit, you could charge, both specialties could charge. Yes.
And then I see Barbara answered my question about what did they talk about in their provider meeting. He was frustrated that I didn't tell him about the code January 1st. We went over the longitudinal care aspect. He wants examples and a possible template from me. And that's kind of what we were describing earlier, Barbara. I mean, if you look at that charge request, the change request that I put up, the link for the 13473, it says that there is no documentation requirement. So they're not looking for something specific that I could say, if you have a template that has this exact bullet point or this exact phrase on it, you should be able to, get the G2211 and not worry about having to pay it back. There really isn't anything that you can kind of go to. It's not like looking at CPT and saying, okay, you have size, you have site, you have simpler complex, you have acute or chronic, there's nothing like that is surrounding the G2211 code. And I think that might be another reason why people are nervous about it.
Yes.
Like, just tell me what to say. Just tell me what to say.
And then I'm shy. I am not a big proponent of saying create macros and templates for this code either. I think that it needs to be personalized, and it doesn't have to be long, but if you're going to put it in that E&M visit, it needs to be personalized to that patient. And I know I always cringe because it's like you put that statement in there and you can pull 10 different accounts and word for word, verbatim, it's going to be that for all 10 patients. And that is not what this code is for either. So I caution when people say, let me create a micro, let me create a template. I think it needs to be personalized to that entity, that day, that patient, that relationship, that conversation.
Yeah, absolutely. I love that their guidance is there's no additional documentation required. Because the E&M nerd in me, they said just document your E&M correctly and you will have supported the G2211.
Yeah.
But
Pam,
yes, document your E&M correctly, because at the end of the day, that's how we bill for your E&M service. And G2211 is only $16, right?
But the conspiracy theorist in me, they never told us. So now when they come back and start looking at these things, they can say, well, you really didn't show the longitudinal relationship. And then you're stuck to going, but how are we supposed to do that? How are we to do that? You never told us, so, but that's just, that's just my decades in here waiting for somebody to come picking at you,
Yes. But they always backtrack, right? It's always put it out there, let's run with it. And then as time go on, a year later, when they backtrack and they're looking for this, then we're like, well, you said nothing else was required. But that I'm the same way. It's like I'm looking for them to want justification. So I'm like in that internal policy, that best practice, make sure you document it, make sure it's there. That way you don't have to dig it out. You don't have to worry about if one doctor said it one way and another said it another. Just train everybody best practice. And I always use that term, right? Because it's not regulatory, it's not required. But best practice, let's make sure we can defend this if we're asked to.
And I think it's also worth a try to maybe like if it's since it's a new code, it's a new policy that you're creating on your practice, maybe run some audits, internal audits, and then see what documentation looks like. And then if there's you need to train the providers, then train them and tell them, hey, you're not documenting really everything, that relationship between this complex chronic condition, and then so it's not justifying that G2211. So I think that's why it's so important to have those internal audits.
Absolutely. And I say that too, like we have it, we're gonna look at it after the first quarter, then we're gonna look at it again in another couple quarters. Yes, you constantly have to look at it because even with training, like we're gonna provide the training, we're gonna educate, but sometimes they do that training for 30 days, they rocking and rolling. You go back and look in 90 days, they done fell off again. So I think for anything new, you have to constantly remind them, constantly put it out there. So yes, I do agree with Laidy. Constantly have those internal audits and make sure you're checking that documentation and be sure it's supported. Yes.
Yeah, I remember back in the day, a group of physicians I was working with when we were looking at their hospital services, because they were one of the guys that would be a level 3 admit, a level 3 every day, and then a discharge. And, I took this stuff to him and I said, look, doc, as if you just look even at the definition of what a level 3 says. So you're saying your patient isn't coming around, you're having to change the treatment plan, they're very serious, so they're sick, and then you just send them home. And we had talked about this before, Pam. It's one of my favorite sayings that these guys like, because I looked at them and I said, are you sending them home to die? Because they're not. I should see them getting better before they leave the hospital,
Absolutely.
And then we would go back and audit, and then all of a sudden I would see a curve that made sense, and I would see it like Kimberly, and that's why I thought of this, because I would see it for like 3-4 months, and all of a sudden it would start getting a little worse again, and then it would all threes again, and you had to go back to the original thing. So old habits die hard, and not just with our physicians and APP, with us too, right?
Well, yes.
We have to learn all that stuff all the time. So it can be pretty difficult. But I think in a note, though, in my head, if it's an established patient note you're looking at and it says they're here for a follow-up on whatever their condition is, and what medications you've tried in the past, what tests have been done on the patient, if those things are in the note, you're showing that there's that relationship there just by good documentation. And that's probably why CMS has made that point of, we don't really require anything. If the note has everything it's supposed to have in it, that's telling the story.
Kind of like our good friend Sanal Patel says, you got to paint that medical picture.
That's right.
You gotta, paint it so we can follow it along. We don't have to guess, and we can easily see the progression. From either worse to better or better to worse, whichever the situation may be.
Absolutely. Yeah.
I would give them gold stars on their audits, and they would fight over those gold stars, y'all. I mean, I had one come to me and he says, I have to talk to you. And I'm like, yes. And he was like, how come I didn't get a gold star? How come I didn't get a gold star? And I was like, oh, so I mean, I was just like, okay, here, I'll take one on my desk. Here, you can have one.
But
and then, I just wanted to put it out there just to clarify. There's someone have asked, and I have seen it a lot of times on social media, Facebook or LinkedIn, that people ask about G2211. This is a prolonged service. This is not a prolonged service. This is an add-on code to a relationship with a chronic complex condition. So just don't think it's because it can get tend to mix with G2212, which is prolonged service. So it's not the same thing.
That one digit makes all the difference. That's a
great point, Laidy.
Yes, very good.
Absolutely.
That one digit on the end makes all the difference. I also saw someone ask, is it valid to submit? Bashar asked, is it valid to submit modifier 25 on the CPT G2211 when reporting with an E&M for a specialist? And so, no, you should not be putting modifier 25 on that G2211. And then that MLN that Betty put in there, it tells you if modifier 25 is being submitted anywhere on your claim, it wouldn't be appropriate to bill G2211. So just to answer
that doesn't matter if you're a specialist or not.
No, it doesn't.
Any,
No.
if there's an E&M with a modifier 25 on it, then that G2211 does not go on the claim form.
Yes.
They're mutually exclusive.
Yes.
Yes.
Just to answer his question on that, I saw that. I'm like, I know,
Thanks, Kimberly.
I know a lot of there's a lot of confusion, right, about
yes,
if it's okay to bill with a modifier 25 not and all that. I like to try to point that out. You cannot.
Mm-hmm.
Mm-hmm.
and
Another thing,
go ahead.
For those of us that are still struggling with how do we create a compliance plan around this, right? Create our policies. If we learned nothing else during the pandemic, we learned that we needed to save the policies on the date that we read them, because they might not still be available the next day or 10 minutes from when we read them, right? Y'all save that MLN.
That's right, Pam.
Have it as part of your policy, because the MLN is what tells us we don't have to have additional documentation. Just do a good job doing patient care and get the work that you did doing the patient care out of your head and into your note. And if you do that, G2211 is supported.
That's it. Think and ink, right?
If you think it, ink it, right, ladies?
Absolutely.
And I was going to say to that, right now I start speaking more and I have a presentation about resources. So I always say, like, you know what, you don't need to remember everything. You just need to know where to find that source and make sure. I learned this from the three of you. You need to know the source so then you can back it up what you're saying, because an opinion is just an opinion. But when you have a source, now it comes credible.
Yes. And
That's
I'm
right.
going to tell you, my providers and the people I talk to and educate in management, they don't want to hear what I have to say. They could care less.
Exactly.
I call them my Kimberlyisms. Trust me, they have no weight.
Don't take my word, but take this source.
They like the cute term, but that Kimberlyism means nothing to them. They want to see the regulatory, right? They want to see that black and white from our regulatory guidance that tells us, like Pam said, that says no additional documentation is required. So yes, and I am so glad you thought to say that, Pam, because there were so many changes during COVID, right? We could hardly keep up. Had I not got that tip from you early on to save those documents, I would have been lost. So yes, I created me a COVID folder, and every time after I heard that from you, I was putting that stuff in there, and I'm doing the same thing with G2211. And now it's okay to bookmark it, but remember, your bookmark is the website. So if the website gets updated, you're going to lose that information. So you want to download it and keep it in a file, because that bookmark is good, but you want that actually information. So save it on your hard drive, your desktop, whatever. That is an excellent tip, Pam.
Yeah, when I was at one organization, we had, I don't even remember how many clinics we had, but there was like 400, providers. So it was pretty sizable. And so when I was doing audits and put things together, as if y'all have ever seen any of my reports, I always have any of my presentations. I got 2 slides full of resources at the end of it, right? So when I would put something together, they'd ask me about something, and I would say, I'll get back to you. I would go and research it. I would write them something up. I would put all the resources in it. I would copy and print out all of those resources. This was back in the day when we had to print everything, y'all. So, and then I would, go back to them, and I would take it out, and I'd get a packet like this from me, and I do that every time. And it got to where they would ask me something, and I would say, you can or can't because of XYZ. And I said, but I'll get you. And they'd go, no, that's okay. You're telling me, I know I can't do it. It's okay. I'm good. I got tired. Okay,
Oh, yeah.
but you have to be able to back up what you say.
You do.
You know,
Yeah.
and if it's your opinion, say it's
Mhm.
your opinion,
That's
but
right.
say why it's your
That's
opinion.
right.
Like, there's not anything in black and white, but they have
Mhm.
these things that kind of, you know,
Mhm.
make it seem like that this is what, you know, blah, blah, blah. But yeah, you always need all that stuff with you. Always have it, you know, to where you can get your hands on something when you're talking to, because if you're thinking about it, we're on our side of the field on the job stuff. It's our side of it that's getting the money for them. They're doing all the work, but it's up to us to get them paid for it.
Mhm.
So, you know, we have to be able to make sure when what we're saying, what we're doing, what we're putting out there, you know, is valid and will stand up, because we can get you paid for anything. You
That's
know,
right.
you tell me, you know, if it's not in the book, there's an unlisted code, you know, so we can get that out there, you know. So I don't care what you did, I can get you paid for it. So it's not about getting paid for it, it's about keeping the payment you got for it. You know,
Mhm.
that's the part, not having to pay it back with interest, with fines, with paying consultants and paying healthcare attorneys and paying, you know, and all the anxiety and everything else that goes with it. Get paid right the first time. Everybody's happy, you
That's
know?
right.
Yeah.
Exactly.
I tell them, we it doesn't matter how we get to Rome, right? Long as we all get to Rome and we have that supporting documentation to make sure we can stay in Rome. Nobody wants
Yep,
to go backwards, having to give that money back, right? So
that's
yes,
right.
yeah,
Well, it takes so
All
long to
right.
post that too.
I know.
Oh,
I was talking about recoupments the other day with my students and just telling them how it's funny you bring that up, because I was like, I was determined I was going to master recoupments. But you're right. It's even that process alone brings on a whole nother level of stress, right? Who wants to go through that? No.
Exactly. All right. So, great discussion on G22, y'all. I appreciate it so much. I think it's just a very interesting thing that I think people are a little worked up over,
Mhm.
with I think with good reason, just because everybody's kind of murky about it, and so everybody's you know, freaking out about it, because they said first 100% and then they were down to now it's only 38% of the time they expect you to use it. So you're kind of just wondering like what's going on with it. But I hope for those of y'all that are on with us today, some of our comments and some of y'all's comments, thank you for making comments about them and asking questions, were a little bit helpful to you in kind of trying to think of where you're going with it and feeling a little more comfortable in using it and talking to your physicians and APPs about it. But we got about 10 minutes left, so I just wanted to kind of touch on the Change Healthcare cyber attack thing.
Yeah.
And you know, I thought it's not, I don't want to say funny, because I don't think messing with anybody's money is funny, believe me. But what I found interesting was Medicare, you know, coming up with this, we'll give you 30 days worth of paid claims and blah, blah, blah. But, you know, then they have a whole page of, but first you have to do this and you have to do this and you have to do. I don't think Medicare is being the most helpful with this. I mean, bless their hearts, they said they're doing something, but when you look through at all the hoops that these providers have to jump through to get that loan, it's not a loan. If they want to get that upfront payment from them is kind of difficult, I think. But with the
yeah.
Change Healthcare thing, for anybody that doesn't know, Change Healthcare, which is under United Health Group, was hit by a cyber attack, and they found it was done by that black cat, black tree, black whatever, that group in Russia. I don't know what
The black cat.
okay, it's like it's a black something, black cat, black dog. I don't know. So
I know, it's
they
really
got
something black.
I don't know. Got in their system, and they took 5 terabytes of information before they caught on and stopped it. So now, and I find this interesting, just now, the government is saying, well, we are going to look and see if any PHI was in that. Well, shouldn't you have done that? Like a what?
Yes.
What?
What do you say? Proactive and not reactive. Can we get there, right? Oh my
Like, oh
goodness.
my gosh.
Yeah.
But so they about 50% of all claims in the United States goes through Change Healthcare's clearinghouses. So I mean, that's how serious. When it went down, it went down. It was like everything for those people that are involved with it. And I think the latest thing I just read, just for y'all who are still, it says the company says the electronic payment platform will be reestablished March 15th. So today, and it expects to start testing and establishing claims network connectivity by March 18th, with service restored throughout that week. So according to Change Healthcare, at the moment, next week is supposed to be, our up and running. We're back to go again. Now, Pam, because you're, again, the billing service, I thought I'd start with you in like, how have your clients been doing through all of this? I know not everybody goes through Change, because like I said, but half the country does. So I'm assuming some of your people might have got touched by it.
So only the clients that we help that are on Athena have gotten the significant impact. And that's because Athena's premier clearinghouse is Change Healthcare. But we don't full on do their billing. We just kind of check their work buckets that Athena doesn't do. All of my other clients, all but one, use TriZetto. The other one uses Waystar. And I have to give kudos to both of them, because we have gotten daily emails updating us on the status of what's going on. As of this morning, TriZetto has actually rerouted 96% of the claims. For all of our clients, that covers about 30 providers, I have probably 20 claims that are actually holding because of the breach. And
That's
it
wonderful.
absolutely blew my mind, because, Change is owned by United Health Group, which equals United Healthcare, right? None of our UHC stuff has been impacted.
Nice.
Our government payers, CANPS, Champ VA, those have been impacted. Those claims are on hold. And some of the smaller payers that process through Change Healthcare, but those smaller payers also equal smaller volume to my clients. One of the things I heard a rumor today, I do not have anything official to back it up, but I heard a rumor that the VA and the federal government actually paid a good portion of the ransom.
Whoa.
And I'm like, wait a minute, why? Why can't we hold Change responsible for this? Why are our taxpayer dollars paying for this? Except that somewhere along the line, we cannot have our healthcare system completely crippled because of this cyber attack.
Yeah, but Change Healthcare being owned by United Health Group is not like they're hurting for cash on their end. So I'm with you there, Pam.
No. And they're the big boys on the block. I actually think, my personal opinion, they've gotten too big for their britches. I do not believe that a payer should be a clearinghouse, nor should they be a provider. And they also should not be handling our prescriptions. They should be a payer.
Yeah, I agree. And they also, I know that they called the Change Healthcare people up. They got called to the big house, to get a talking to. And so I don't think by any means they're done with the investigation part of it. But, it's like, what part of your cybersecurity was so lacking that it let these guys in the first place? Now I know these are people, and I make jokes about it because in my head, because I was having a conversation with some clients yesterday, and the doctor, she kept trying to get something. She couldn't. So she says, hold on a minute. And she gets up and she walked out of the room, and I heard her talking to somebody else, and she came back in and she sat down. She said, I couldn't get that thing on my phone to stop working. So I had to go give it to my kid to help her do it for me. So I'm like, that's it. If you know how to do something for us, go ask an 11-year-old. So, I always get this picture, that there's these little kids sitting somewhere that, have been living and breathing this stuff. But I mean, these are sophisticated groups that get into all kinds of things. And but that means that, if you're doing half the claims, I'm sorry, you need to have some sophisticated stuff on your side. Go hire your grandchildren to help you out.
I know, I'm telling you, it's amazing because my 7-year-old Sage, honey, she can whip circles around me on my iPad and my laptop. And I mean, these little kids, they come out knowing this technology. So I definitely get what you're talking about.
And again, I'm not making light of this at all, because I know for some people they're really hurting because of this, and I'm very sorry about that. But I totally put this on Change Healthcare. I don't, nobody else, and I don't think anybody else should be responsible for it. But their thing says they should be, up and trying to get in there next week. Kimberly or Lady, were y'all's claims? Did y'all have any effect? Or I know it wasn't just claims either. It was also prescriptions, as Pam was saying. A lot of patients couldn't get their prescriptions. They had to pay out of pocket. And for some people, those medications with no insurance, thousands of dollars. And, think of the diabetic patients that were having to pay for their insulin out of pocket and stuff. I mean, that's just, that's awful for those patients.
Yeah, so for me, no, actually, I haven't heard any upfront talk, I've kind of been disconnected from that part of it, but I have not heard any entities that I'm closely connected to have been affected majorly. So
how about you, Lady?
Yeah, we didn't were affected by anything. I don't think we use, my organization doesn't use Change as a clearinghouse. We do use Encoder, and I think some of the accounts were like not able to access Encoder. But other than that, nothing. But it just gets me in a, be conscious that, cyber ransomware or anything like that, Black Hat or anything attacks, they're gonna happen all the time. So we have to do our due diligence to make sure we protect and we protect the practices where we work. As individuals, if we see something coming up into our email, don't open it. Like, they have, or maybe having a policy for those phishing stimulations that we can get from email, and making sure that our employees understand that when something comes in, do not open it and send it to IT or send it to cybersecurity, because that we have to do our due diligence to protect the whole entire organization.
Oh, yes.
I tell y'all.
Yeah, I do agree with you on that, because that is the thing. And even in my entity, we constantly, especially in new hire orientation, we go through it and we tell everyone, and we have something set up in our system that if you think something is suspicious and you worry about it, you can click one button. It'll send it over to IT so they can investigate it. They can let you know if it's good or not before you even click on it. Yes, I do think we at frontline, right? That's just our little small part we can play. Got to make sure things stay safe.
I did some work for a consulting firm, and they gave me a laptop. I had to use theirs because it was all encrypted and everything was all, and so I had to do this little mini training, to go through for them. And I'm like, okay, so you go listen to all the modules, you're like, whatever. They gave me an email with their company, and I'm like, okay. So I logged in, I had an email that said it was from somebody in the company, and that asked me to like click some attachment or to open something. And I'm looking at it, I'm like, that's just, that's weird. I don't know who that is. So I clicked the forward to forward it to somebody else and ask them about it. And when I clicked the forward, a little thing popped up. They were faking me out. They were testing to see if I was going to open it or not.
Simulation.
A little sneak, but
well, I'm glad you passed.
a thing popped up and was like, oh, you passed. Like, we were just trying to see, blah, blah, blah. Always remember, never open attachments from, and I was like, wow. that was pretty
And you know what,
sneaky.
you know what? When I went to my cybersecurity, we get education at class. Sometimes the fonts or the wording, it looks the same. Like they make us to understand just the font itself. Sometimes they use different type of fonts, and that's where sometimes we're so busy, and then we just want to get bypass our emails. It's best just to take your time when you're responding or viewing emails to make sure you don't open something that you were not supposed to. Take your time, do your due diligence. I cannot emphasize enough, because you are helping your practice, but you're not just helping your practice or your entity. You are making sure the patient's information is protected.
Oh, yes.
Yep.
Yeah, absolutely. And you're securing your position, because I'm going to tell you, if there's a breach, you're going to have to be accountable for that, right? That's my compliance brain going off over here. And so you don't want to be.
I don't want to be named in some report. Well, Betty.
I do not want Kimberly Jolivette Williams listed for that type of stuff at all. So you want to do your due diligence.
It's an anti-Kimberlyism.
Yes,
I love it, Pam. I love it.
All right, ladies. We are at the top of the hour.
Wow.
This has been just a ton of fun. Thank you all so much for coming on. So everybody watching today, please, thank Pam Vanderbilt, Laidy Martinez, and Kimberly Jolivette Williams for joining me today. And I'm sure they've all guested before, and they'll all guest again to help me out and talk about different subjects. So thanks for spending some time with us. And I look forward to seeing y'all on the next healthcare happenings, where you can come in and see what is happening in healthcare. So until then, y'all have a good Friday. And again, happy St. Patrick's Day.
That's right. Have a wonderful
Bye,
Friday.
everyone.
See you later, my friends.